Welcome to the presentation of Improved Hemoglobin A1Cs, Navajo Type 2 Diabetics through Uniform Education, conducted and presented by myself, Adrian Hutson, through Maryville University. Committee members include Faculty Chair Dr. Crystal, Second Reader Dr. Snow, Third Reader Dr. Dodge. Many Navajo people have type 2 diabetes. Several of my patients know that financial barriers are limiters to improved health. A promoted walking program can be an economical and effective way to improve health in Navajo diabetic patients. Type 2 diabetes is the most expensive chronic disease in the United States. Over 5.2 million Native Americans have type 2 diabetes. Many Native Americans have poor social conditions and economic adversity. We at Fort Defiance Indian Hospital service the Navajo Nation capital of Window Rock and several other communities. One benefit of the project is to show that the nation is willing to support education, growth, and advancement on the reservation. Type 2 diabetes is quite prevalent on the reservation. This project could provide another clinical tool for patients to utilize to improve A1Cs in diabetics. Outpatient primary care providers can play an important role in improving diabetic patient outcomes. There was no previous uniform educational material implemented to provide type 2 diabetic patients in the outpatient clinic. The American Diabetes Association guidelines recommend a minimum of 150 minutes of physical activity a week. This standard served as a framework for the education and literature provided to address a uniform educational approach in the outpatient clinic, improving knowledge about exercise, especially walking, and expanding self-efficacy, confidence, and exercise. The literature review provided a solid foundation for the establishment of the upcoming A1C reduction project. There were many similarities between the articles, and there were a few differences. The review allowed for a robust increase in knowledge, which may be beneficial to diabetic patients. The 10 articles from the review of literature were grouped into the following 3 themes. Number 1, effects of exercise on glycemic control. Non-pharmacological interventions are essential in reducing glycated hemoglobin A1C in diabetic patients. Second, A1C monitoring. The A1C was first recommended as a biomarker to monitor blood glucose control in 1976. A person's A1C indicates their glycemic story of the 3 months prior. An A1C lab value has a correlation to the risk of complications from long-term diabetes. Testing for A1C is convenient due to it not being sensitive to the time of day or fasting status of the individual being tested. Third, the use of education to improve glycemic control. Several studies were reviewed which indicated people benefit from education about nutrition, diabetes, and what they can do to reduce their A1C. Historically, Navajo people do not discuss disease processes because they feel they will invite a disease upon themselves. Therefore, culturally, it is a social norm for diabetes not to be discussed. This project is most represented by Asians' theory of planned behavior. The theory focuses on 3 core elements: attitude, subjective norm, and perceived behavioral control. The first dimension of this framework is attitude. In this project, the attitude refers to the self-control perceptions of many diabetic patients who feel their diabetes is under control if they feel well. As a result, they often will stop taking their medications or even monitoring their blood sugars. Even if their A1C is above 14, they do not feel motivated to change their habit because they feel normal. Lab values and hard data do not always influence their attitude towards diabetes. The second dimension of the framework is a subjective norm. There are many people on the Navajo reservation with type 2 diabetes. It is a common disease process in many households. Due to this, they might not feel it is something abnormal that should be addressed. The final dimension of the framework is perceived behavioral control. Having blood glucose above goal for years despite perceived effort might influence attitude towards improving their A1C. Individuals might feel that control of type 2 diabetes is out of reach. The purpose of this project was to determine if the implementation of a uniform educational approach to teaching decreases A1C in diabetic patients versus usual care. A standardized process of education for healthcare providers who monitor and follow these patients and evaluate prospective charts on a macro level was implemented. This was used to determine if A1C results changed from normal to abnormal, or if there's an elevation over time until the next follow-up appointment. The investigator compared one dependent variable, the A1C, to one dependent variable that monitored A1C levels prior to and following standardized diabetes education for providers implementation. The setting is an outpatient primary care clinic located in Fort Defiance, Arizona. The clinic serves a Native American population of predominantly low-income, high-risk chronic disease individuals, especially those with diabetes. Participants: the 11 outpatient clinic providers received education about the materials and the sample population. The providers were instructed on the scope and duration of the project and how to address the intended audience with the information. The project was a quantitative exploratory design. A retrospective chart review was performed to look for correlations in the data as an effect of the project. Electronic medical records, EMRs, were utilized for data collection. The study period began September 7, 2023 and ran until April 9, 2024. The sample. Inclusion criteria involved having people age 18 to 65. They had to have a diagnosis of type 2 diabetes. In the scope of practice for the clinic, diabetes management is offered. Diabetes services include lab monitoring, medication management, and referrals for sequelae of diabetes. This project focuses on diabetes management, specifically for patients who are impaneled with an outpatient provider at Fort Defiance Indian Hospital and receive routine care. These people were seen and evaluated at Fort Defiance Indian Hospital outpatient clinic from September 7, 2023 to April 9, 2024. The exclusion criteria: they could not be under the age of 18 or older than 65. They could not have a history of cancer, no recent injuries, no history of chronic pain. Patients participating in physical therapy were also excluded, and patients on oxygen. This approach was selected because the data was readily available, practical in terms of costs and time expended, and allowed for the collection of data from a relatively large number of cases. Participants in this project are described as adult patients on the Navajo Indian Reservation in the southwestern region of the United States. Participants' identifiers were removed from the data. The ethnic background of the sample included 100% Navajo tribal Indians, as the facility is designed to serve Navajo Native Americans. If a non-native individual is seen in the ER and need to be admitted inpatient, they are sent to another facility. Independent samples t-test. The set of data is descriptive for both pre-A1C values and post-A1C values. This is descriptive because the data collected represents a whole group. Aggregate data was collected to not have specific subjects or participants for the study. The next set of information produced is through the test for normality. For an independent sample t-test to be run, certain assumptions must be met. One of the assumptions is that the dependent variable, the A1C, must be normally distributed. In this case, each sample had a few extreme outliers, and the data steadily flowed out the left of each histogram, which are represented on the following slide. The Shapiro-Wilk test. Next, the Shapiro-Wilk normality test was run for pre and post values, and both found significance. The p-value was less than 0.05. This violates the assumption of normality. Mann-Whitney U. Because there is a violated assumption, the independent samples t-test cannot be used. Therefore, the non-parametric equivalent, a Mann-Whitney U, was conducted. A Mann-Whitney U test was used to determine the statistical significance of the difference in A1C test results comparing the usual care group and the educational intervention group. On average, the A1C was better post-intervention at 7.3 than before at 7.6. As the histograms indicate, there are a few extreme outliers, and the data steadily flowed out to the left of each histogram. The p-value of 0.056 is slightly greater than the level of significance of 0.05. The figures show there are no statistically significant differences in the pre and post intervention groups. Thus, there is not a statistically significant difference in the pre and post A1C scores. There were some limitations to the implementation of this project. Some bigger factors included implementing the project around COVID. Initially, due to the COVID-19 pandemic, many administration staff were reassigned responsibilities to help with the pandemic, which limited their ability to complete their normal responsibilities, which contributed to the delays. Then, changing post-COVID related restrictions and shifts in departmental responsibilities made it difficult to get the project approved. Additionally, the resolution of the COVID-19 pandemic affected communication between members of the organization and the researcher, as many members were changing work protocols, which caused delays in communication. The original IRB chair, Internal Review Board, at the study site resigned in 2023 without notifying the researcher. The study was initiated in the fall, ran through the winter, and ended mid-spring. For some, due to the cooler weather, physical activity might diminish. Ice, snow, these things make it difficult to exercise outside or even get to the gym. As a side note, I have observed people's charted weights increase during these times. Time of year could have had an impact on results due to the holidays. Halloween, Thanksgiving, Christmas, New Year's could contribute to increased weight, food consumption. Time was a significant factor in the study because several months were required to obtain an adequate number of patients treated under the revised Uniform Diabetic Education in order to assess the effectiveness of the revised Uniform Diabetic Education. Length of the study might have limited the results. Having a larger sample size could lead to results which indicate statistical significance in the data collected. The project strove to improve outcomes and quality of care that is provided to type 2 diabetic patients seen in the outpatient clinic by robust and efficient care to reduce sequelae of type 2 diabetes. Due to financial constraints, there are many people on the Navajo Indian Reservation without internet. For those who subscribe to internet services, myself included, having a strong connection can be a challenge due to a lack of infrastructure. Cellular services can also be severely limited or lacking altogether in areas on the reservation. Due to internet and cellular issues, designing an application for the patients to use on their phone or online would have limited use. The results indicate that further research is needed. Such findings suggest that compliance with a uniform exercise education for diabetic patients could promote improved self-care in diabetic patients. It is possible that the successful implementation of the program could prevent unfavorable healthcare outcomes, such as hospital admissions for patients. Generalizable results could prompt sustainable change in this and similar organizations, resulting in greater positive outcomes for this population. The strengths of the Uniform Exercise Education for Diabetic Patients project included a comparison of a low-cost intervention, allowing outpatient clinicians to promote a uniform approach to diabetic patient education, which did not increase the cost of the facility or patients. Although the data analysis did not demonstrate statistical significance in reducing A1Cs, this approach may lead to a positive impact on weight loss over time and with coaching from the healthcare providers. Healthcare providers can discuss the potential effects of the preferred physical activity strategies of diabetic patients on how to utilize the options to fit their preferences and needs. Staff were willing to participate, which was a bonus. Also, the project follows the American Diabetes Association ADA healthcare guidelines. This project highlights the application of evidence-based practice in remote healthcare facilities. Healthcare education helps to break down barriers related to healthcare literacy and empower patients with tools for self-care. The recommendation would be for a common course or materials to be provided to all diabetic patients in the outpatient setting. Scheduled, regular, aggregate A1C monitoring could indicate if the selected education drives the desired outcome. The Uniform Physical Activity Education Outpatient Intervention did not show a statistically significant improvement in outpatient type 2 diabetic patients. A positive correlation in the data suggests that the idea is plausible, though. Another impactful message from this project is that not all interventions have to be pharmaceutical in nature. Also, not all health interventions need to cost much money to have a net benefit. Using the same research setup and design, a larger sample size, along with a larger duration for data collection, might yield different results. Future studies might benefit from being in the Navajo language. To drive sustainable change, this project can be shared with management to point out the importance of a common voice from the outpatient providers regarding type 2 diabetes. By using this project as a starting point of conversation, hopefully, There will be a robust communication channel between several departments to provide additional opportunities for walk-in and exercise for the community without needing to see a healthcare provider. Once this project is finalized, it will eventually be presented to the IRB committee for review via oral presentation. The final paper will be sent to the previous directors and other staff members involved in the approval process who might not be part of the facility IRB. Personal impact. First of all, I'd like to thank Fort Defiance Indian Hospital, its staff, and the local community for their support and allowing me to do this project. Thank you to Dr. Whitehair for helping to drive this project through and being a huge support. I'd like to thank Dr. Dodge, who has been there since the beginning. I'd like to thank Dr. Crystal, Dr. Snell for their support and guidance, especially toward the end of the program. I believe that one of the intentional takeaways of this project is the time it takes to implement change in any facility, whether it's big or small. This opportunity drove me to engage with many of the leaders at the hospital who I would not know to this day if not for this project. One of the key ideas learned from this project is how many people might be involved in such a project in an outpatient clinic in a small facility in the Arizona high desert. Questions? These are my references. Thank you for watching.